All right, good evening. Can you all hear in the back? On behalf of the Student Global Health Initiative and the Latino Medical Student Association, we want to welcome you all to our second Breaking Barriers in our panel series. And tonight we'll have an all-star cast that are going to be talking about all kinds of great issues. But before we get started, a couple things. There's snacks, we have cookies in the back, and also our water just appeared, so you can grab some water if you like. If you haven't signed in, there's sign-up sheets going around. That would really help us because the more people that are signed in, the more chance we get snacks in our next event. So that would be really helpful to us. Also, there's a little column there that says to rate the event. If you get the paper later on in the event, feel free to add something in there. That would be great. We also want to let you know about a couple upcoming events. Our third panel's event should be in March, and we hope to feature a panel from representing Native American groups in Utah. So we're really excited about that, so stay tuned. We hope that you'll join us for that event. And also, April 13th, please put on your calendars, the Student Global Health Initiative Annual Global Health Conference will be taking place. It's Friday, April 13th. We have some really fantastic speakers. I don't know if you went last year, I did. It was a really great event, so I hope that you'll join us for that again. We're going to start with a presentation, and then we're going to have a Q&A session at the end. So if you want to shout your question out in the middle, feel free, but also keep in mind that we'll have a more open time for dialogue towards the end of the presentation. And without further ado, and if you're coming in late, don't forget to sign in. That would be really helpful. I'm going to pass off the microphone and go ahead and get us started. All right.
How's it all? Good? Well, my name is Hugo Bravo. I am a first-year physician assistant student here at the university. And first of all, I just want to thank all of you guys for coming out tonight. I hope that we can answer a lot of your questions and maybe some misconceptions or truths around the Latino culture or Hispanic Latino culture. And what we're presenting tonight is more of just a general overview about the Latino culture. So, and by no means does this represent or encompass everybody who identifies themselves as a Latino. So keep that in mind. So I want to take the time to read this here for you. So in the summer of 1988, a Mexican family immigrated to the U.S. in search of a better future. Both parents took their youngest child, a 3-year-old boy, and left the other 3 children with their grandparents because they couldn't afford to bring everyone along. They tested their luck at the Mexicali border crossing in Southern California. The mother was deported twice as she attempted to cross illegally through the desert. She almost lost her life on one of the occasions as she ran from the border patrol and nearly fell down a large canyon. Luckily, she made it across on her 3rd attempt and reunited with her husband and child who hadn't heard from her in over a week. 8 months later, the remaining 3 children made a journey with their father, who returned after earning enough money to pay for their passage. Whether by destiny or pure luck, these children made it across on their first attempt. This was just the beginning of countless struggles and hardships faced by this family as they attempted to assimilate into the American culture. So I tell you the story because this is my personal story. This is my family's personal story crossing the border here into the United States. And although our family story was that of prosperity and the American dream, many other families aren't so lucky. So this is just this is a statistic here. It's estimated that 385 deaths per year happen at the U.S.-Mexico border. The study was done. These are numbers from 2000 to 2009, and this was from the U.S. Customs and Border Protection. So most of these individuals died from exposure to the elements, things like hypothermia or dehydration. But what I want to point out is that although these numbers are significant, these numbers only identify the bodies that were found. So the numbers are actually bigger if you consider people who, bodies that were never found or bodies that ended up, along the Rio Grande on the Mexican border, or many who died on their journey through Mexico. So I want to point this out because I want to make it clear that immigrating into a new country is a tremendous sacrifice, and whether you're legal or illegal. And if you consider the differences in language, culture, economics, or lack of resources, and a lot of times lack of family. So next time you encounter anybody who's immigrated into the U.S., maybe consider or think about the sacrifices or experiences that they may have endured on their journey. So with that being said, many of you may be wondering, well, who is a Latino, or who are the Latinos living amongst us? So we can try to define it by looking at this definition, and this definition is from the U.S. Census Bureau, and it says Hispanic or Latino refers to a person of Cuban, Mexican, Puerto Rican, South or Central American, or other Spanish culture or origin, regardless of race. So this is obviously a very broad definition, and I don't think that it really helps us define any particular individual. We can look at this list here, and this is a list of the countries that possibly make up this category. So there's a total of 21 countries here, and when you think about it, if you pick any of these countries, the differences between their people, their culture are immense. So, you know, when you combine all of them and you group them into the Hispanic culture, it's, you know, there's a lot of differences. So what does this really mean? And it means that Hispanics come with a variety of culture, beliefs, race, and individual backgrounds. So as providers, we really need to take the time to understand our patients' needs, their expectations, and their personal beliefs. So for those of you actually here who may have the clinical experience working with people from a variety of cultures or backgrounds, you understand the importance of getting to know your patient and what that means in terms of outcomes for both, positive outcomes for both providers and patients. But for those of you here who may not have the, who may lack the experience or that intimate exposure to people outside your race or your culture or your belief system, if you can grasp the idea of being open-minded to other people's beliefs and accepting those beliefs to be just as valid as yours, then you're going to be better off in the long run, and you're going to have less misunderstandings with your patients. This just shows you some of the benefits that we can see. We see that we provide better health care. We as providers are going to have better satisfaction. We're going to improve patient compliance and increase the number of visits or return visits and their satisfaction, patient satisfaction. But most importantly, we're going to make a positive impact on healthcare. And I mean, this is personally one of the reasons that I'm in this field, and I think a lot of the people in healthcare join for the same reason. These are some statistics. The Hispanic population in the U.S. in 2010. So, as you can see, the total U.S. population is 308 million, and about 16% of that population is made up by Hispanics, which is, you can see it's a little bit over 50 million. And these are the states where Hispanics are most concentrated: California, Texas, Florida, and New York. And this is all from the U.S. Census Bureau. Utah's numbers are actually fairly small compared to the rest of the states. So this is the population, the 2010 census here in Utah. So we see 2,760,000, almost 4,000 people. And it's important to point out that the population actually increased almost 24% in a period of about 10 years. And a lot of those, that increase was from Hispanics. And you can see that 13% of all Utah is Hispanic. And we break it down to Salt Lake City. We're a little bit more concentrated here in Salt Lake City at 22%. So this is a little bit of just kind of health status information on Utah's Hispanics. And this is from the Utah Department of Health. It's a study that came out in 2010, and it focuses the period between 2006 and 2008. So the first thing we see is age distribution. So the median age for Hispanics was 24.4 years, and this is actually significantly younger than most of the population in Utah. So with young Hispanics, we tend to see high fertility rates, and this in turn means that the Hispanic population is going to continue to grow over the future significantly. So if you practice in Utah, you're likely going to have a Hispanic patient, so get to know them. And the other thing that this helps us with is it helps us focus on the need for things like family planning or age-appropriate screenings for certain population. Next, we look at life expectancy, and life expectancy didn't vary so much. Everybody's living a lot longer now, but Hispanics are living on average about 80 years, second to the Asian population, which is about 83 years, I think, 82 or 83 years. And again, it's important to point out that a small increase in life expectancy turns into a very large increase in population over time. So again, this reinforces what I talked about with age distribution. And not only that, but the longer we're living, the more you're going to run into chronic disease states. So we're going to have to be dealing with a lot of different chronic disease states. And this is not just for Hispanics, but for all populations, because better medicine, better treatment, we're living longer. When we look at poverty, actually, the poverty rates here for Hispanics in Utah were very high compared to the average. I think the average was about 10%, or it was in the low teens. So the Hispanics are at a very high poverty level compared to the rest of the population. And I just want to point out that the poverty guideline for 2009 for this study showed that or defined poverty as a family of 4 making less than $22,000 a year. So if you're making that or less, you're considered to be in poverty. And this is important because poverty is an indicator of the financial resources that are available for basic necessities such as food, clothing, and healthcare. So if you're poor, you're already at a huge disadvantage. The next two are very related. So we look at not having health insurance and not having a primary care physician. And these numbers, again, were the highest among all other ethnic groups, with 31 and 21. And the thing I want to point out here is that, and I think everybody knows that the fewer and less timely preventative care, preventative care and screening services that we get, that tends to lead to a higher morbidity and premature death when compared to people who do have insurance. So that concludes my part of the presentation, so I'll turn it over to Maggie.
Can you guys hear me? Do you guys have any questions for Hugo so far?
What do you think contributes to the high rate of poverty among Hispanics?
What do I think about it?
What contributes to a high rate of poverty?
And why it's obviously extremely high. I mean, I guess
Why?
why? Well, I think a lot of it has to do that you're seeing immigrants that are coming to the U.S. They typically leave their countries because they're in poverty. So they're looking for a better life. So when they get here, they don't have the resources. You got to learn a new language. A lot of them don't have the education, and if they do, they can be doctors in Mexico, but that doesn't matter here. They're working as janitors or whatever job they can get to support their family. So I think there's a lot of reasons why this is they're really high in poverty, but those may be some. And I think one of the presenters, somebody else is going to talk about poverty levels. I think you were.
I can address a little bit also. I was talking my mom one day about we were talking about daycare, and I know some individuals, some women who do daycare, in the Latino family, and also I know some. I have family, Asian family, and they speak English, for example. And the Latino family, usually some women work for $1 per hour to take care of your baby. And my cousin, who is Asian, she charge like $100 per day for take care of one child. Other reason, for example, is when you get to this country and you don't speak the language, you need to get a job, whatever job that you can get. And if you need to health insurance if you need healthcare services, and and you go to the emergency room, you get a big bill. And the poverty cycle starts. And you have a daughter who is 15 years old, get pregnant, and they don't finish school. So there is a lot of cycle of poverty in those communities. And maybe that's one of the reasons they can think right now.
Any other questions so far? Okay. Well, let me tell you guys a little bit about myself. My name is Madeline. I go by Maddie Torres. I'm a first-year medical student. I was born and raised in El Salvador. I moved here when I was 9 years old. My story actually is not as my story of immigration is not as hard or rough as you would call Udo's. I was actually lucky to migrate to the States legally. So that was a little nicer, but it was still not easy to learn a new language and acclimate to a new culture. So it was a little rough, but you know, you just gotta get used to it. And one of the things I learned is that the younger you come, it's the better. So the majority of our immigrants are actually of an older age, and that makes it a little harder to learn a new language to acclimate to a new culture. What I will talk to you about today is the cultural differences in healthcare. So growing up, and actually a lot of people here might relate to this, I was told for the longest time ever to never walk barefoot on the floor because you would get like pneumonia. I have cousins that were raised believing that when they had their menses or their menstrual cycle, they should not do anything because that's considered a disease. So one of the things I wanted to talk to you guys about is taking into consideration beliefs that people have about general diseases, chronic illnesses versus acute, and also taking those into consideration that we as providers do not want to dismiss those beliefs because that will have a huge impact in how they do compliance, how they become compliant with our treatment, and also whether or not they come back or even seek healthcare when they get sick again. This is a picture actually about one of the misconceptions, or not even misconceptions, but old beliefs that I will be talking to you about. This is a little bracelet babies wear to for parents to prevent for them to get what they call evil eye, or as we call it in Spanish, mal de ojo. And they wear that because we believe that if a baby gets stared at for a very long time, they will basically develop cold-like symptoms. So they wear little bracelets to prevent that. So we have, there's three major issues that we'll discuss to you guys about when it comes to the cultural differences. One of them is education. The majority of our Latino population is uneducated. A lot of this has to do, like Owen was saying, with a cycle. Parents come, they immigrate. Most of them probably get to elementary school, if not high school education. Few of them are actually professionals in their country, but that does not translate to being a professional in the United States. The second point is religion. The majority of our Hispanics are Roman Catholic, and as you guys might all be aware, based on what different religion you belong to, that changes your perception in life and treatments and testing available to all of us. The third one are folk beliefs, and this is kind of my favorite one. Family community beliefs that get passed down basically after generation and generation. Cultural superstitions that are sometimes old wives' tales, and some of them have a lot of truth to it. So education. In 2000, there were about almost 32.5 million Latinos living in the US, with 30% of Hispanics dropping out of high school. That means that there are actually less than 15% Black and white non-Hispanic. So we actually have the lowest dropping out of high school rate, which is very, very scary. About only 60% of the ones that actually don't drop out complete high school. 50% of the mothers have some high school education, but less than 20% of them hold a bachelor's degree or any other type of professional education. And of the 20% that actually, pardon me, I don't have the figure, but I believe of the 60% that may go to college, only about 10% of them finish. A lot of that has to do with financing your education. A lot of people that are not legal in the country have to pay out-of-state tuition, and some of them are lucky to start, but not lucky to finish. If you are lucky to get a degree, but still are not legal in the US, you cannot basically work with your degree. So a lot of people get discouraged to do that. There are other many factors as family growth, family illnesses. There's many factors that affect our education rate, and that's unfortunate as we can see by the statistics. One of the main things I want to emphasize is what we can do as providers to kind of close that gap that exists between our patients and us. I mean, let's face it, most of our population, our Hispanic population, is undereducated. That gap is going to take years for it to start closing. So we have to try and accommodate our patients so that they don't feel like we're taking them for granted, so that they don't feel like we're treating them like idiots. Undereducated doesn't necessarily mean you're dumb, you're stupid, or you're slow. It just means we have to take away that medical jargon and take the time to explain and get to know our patients. One of the biggest things, and this comes from my personal experience with my mom going to the hospital, is she goes in and doctor says, "Hi, hello, how you doing?" Most of them don't provide a translator. They figure out that since I'm there, I will translate. That's a big no-no. You don't want a family member translating. As much as we love to do it, we usually skip half the conversation because we feel like we have the right to make decisions for them, when we really don't. Second part is they just sit there, and we as providers sometimes get carried away and we tend to make decisions for our patients. We don't explain the condition, maybe because we don't have time or we use our jargon. We sometimes just pick treatment and not give them options. And half the time we just communicate like we probably would with our nurses and our assistants, or we just communicate with our colleagues. We don't take the time to put it in very, very lay terms. And that causes confusion and misconception between our patients and us as providers. One of the biggest things I can tell you guys, avoid medical jargon, even just not with the Hispanic patients, but with every other patient. You want to make sure they understand what is going on. You want to empower, we want to empower patients. We don't want to take that individuality, we don't want to take their self-power away from them. But most importantly, if I can get any one of you guys to walk out here is with the idea that you don't make any assumptions. You don't want to assume that someone, just because they check in their Spanish, they're Hispanic, Latino, automatically speak Spanish. You don't want to assume that just because someone speaks Spanish that they are Mexican. There's, as you guys see, there's an array of countries that we come from. You don't want to assume that just because someone is of darker skin color that they're immediately fall in that category. Or vice versa, because you're a lighter shade, that you don't fall into that. So I actually took the time to compile 2 case scenarios for you guys, and I would appreciate if we all participated. 50-year-old Hispanic woman presents to the emergency room complaining of severe lower back pain, incontinence, and numbness, tingling in the legs. Cauda-Equina syndrome is suspected that emergency surgery is required. You ask the patient to sign consent forms, but find out she can't read, speaks no English, and does not understand her medical condition. If you guys have any idea of how you might approach this? Quinn?
You need a translator.
Yes, that is the first thing you want to get. You do need a translator. So let me put it this way. You know you need this emergency surgery. Would you just get her to sign knowing that she didn't basically know what she was signing and rush into surgery? Or would you take the extra 5-10 minutes to actually get her to understand what is going on before you rush her into surgery? So, yes?
So anytime you have a patient sign consent, you're saying that you're taking the time to explain the situation to the patient. And that consent form is a binding legal document saying that the patient understands. And if they sign it without understanding, they can't be compliant. They could, I mean, there's a lot of fear that goes in with that. And that just causes unnecessary stress, which can affect healing. I mean, there's so many ramifications from not taking that extra 5-10 minutes to make sure the patient really understands why they're signing and what's going on.
How common would it be for a patient like this to make that medical decision on her own or ask for her family members to participate?
The majority of the time you will have family members come in, but some of them might speak English, some of them might not. And if they do, a lot of your community does not understand the extent sometimes of what's going on. What actually happened here is I tweaked a couple of things, but this happened to my mom. My mom had emergency surgery a couple of months ago. My mom actually knows how to read. She speaks a little English. She has a solid medical background. She's actually a nurse in El Salvador. But I actually had to get phone calls many, many times because physicians were not providing a translator and they were not taking the time to actually explain to her in many terms. which caused a lot of stress to her. She didn't know why on earth she was going to surgery. So it can be very, very stressful both for your patient and the family members, and it's just things that could be avoided if you take the extra 5 minutes to get a translator to make sure they understand what's going on. Second thing is religion. About 93% of our Hispanics are Christian, 74% of them are Catholic, and the remaining 18% are Protestant or non-Catholic. So Latinos are the majority are very religious. They believe in whatever God has put in their path, that's the way it's going to follow. We always say, lo que Dios diga, lo que Dios sea, lo que el Señor crea que es mejor. We always believe that God knows best. So we tend to accept whatever brings on, but this should not keep you, however, just because a patient says, I will accept whatever God decides, from offering them different tests, different options. I actually, I was very surprised. I read a paper from Access Medicine, and I think it was in the journal of, it was the AMC that did the study, but a lot of providers tended to assume that because it was a Hispanic female and that they were very religious, they had these misconceptions. They would not actually ask them if they wanted the amniocentesis test, to test for Down syndrome, or to test for any other genetic abnormalities when they were planning a family or when they were having a baby. And it turned out to be the majority of the mothers would have said yes, actually, they wanted the test. And it's important to keep in mind that a genetic test, like amniocentesis, if you have it, doesn't necessarily mean that they're going to have to abort the baby. It just means they're going to inform. So these tests are not necessarily intended to basically keep them or counteract their beliefs, but they're also intended for informing. So misconceptions can lead to lack of communication, and it can actually lead to depriving your patients from tests, from treatments, from many other things that could empower them, that could help them plan better, if not prepare better for many things. So once again, believing in God or any other religious, like any other part of religion that you are, should not impede you, should not keep you from offering treatments, even though you might come in with perception, oh, they're not going to say no. You can try, and that actually doesn't take more than a second to try and ask. So once again, don't assume anything. Go in with a clear mind. Just go in with a clean slot and get to know your patients. That's the best way to be able to provide the best healthcare possible for them. Second scenario, you have a 35-year-old woman who presents to your clinic for a pregnancy check. You suggest the amniocentesis for Down syndrome and other disorders. Patients have been anxious and unsure. She tells you she is Catholic and her family does not believe in abortion. They believe in God's will and let it be lo que quiera Dios. What would you do with this patient? How would you approach it? What would you suggest? Yes?
So I would tell her that, she doesn't have to do an abortion, depending on what the results say. If she wants to know, it could be helpful to prepare for special education or getting family support. But just because she's having a test doesn't mean she has to have an abortion.
And that's one of the things I wanted to emphasize, thank you, that just because you get a test and it might come back positive or negative, or just because you have an assumption that they may not want that test doesn't mean you can't offer it. It doesn't limit you to one thing, it just gives you the option. And as healthcare providers, I believe that's the best thing we can do with the patients, is give them options for their healthcare. Folk beliefs. Let me tell you a little bit about this picture. This is a yolk egg placed in a glass of water, and those are used to do what we call la limpia de huevo, or the egg cleansing. And a lot of Hispanics believe that by doing this, you cleanse yourself from bad spirits, from bad energies, and from bad karmas. So you have the superstitious beliefs. Don't want to know some of you guys about mal de ojo, the evil eye, where the babies get it if they get stared down on, and that's why we wear little bracelets. We believe in witchcraft and full moon and lunar eclipses affecting pregnancies and births and different cycles of our life. We also have different beliefs about chronic diseases, diabetes and hypertension, anxiety, including mental illnesses. A lot of people think that bipolar disorder is a demonic possession. A lot of our culture sees depression as just being a bad spirit living within you. So this is just, it's not a very, you'll find this more from kind of not so much the modern cultures, but a lot of the more traditional cultures. This is just a hierarchy of basically the healing process. So you have the elder, whether it's your grandma or the eldest person in your family, that's the first person you go to. And then you tend to have el yerbero, la partera, y el sobador. La partera is your midwife, and sobador is like the person that gives you a massage so your muscles get better. And then you have your yerbero, which is your medicine man, and he knows what medications or what herbs to use. Lastly, which is at the top of the hierarchy, you have the healer or el curandero, and he is the equivalent of a physician. Now I actually want to put this out there for you guys because a lot of people will do that before going to seek a physician. They will go into what you guys see in the background, which is this kind of mix of a store with a lot of religious artifacts, candles, and herbs to seek healing instead of going to see a physician. And that might affect the way they approach Western medicine. That might actually affect compliance as well when they do in the end come see you and you dismiss their beliefs. Birth effects, like I said, mandeopo, powerful gaze to a baby. It usually happens with kids, but it can happen with adults. And then you end up with cold, flu-like symptoms. You usually treat it by having that person that gave you the powerful gaze touching you, and you prevent it by having them wear the little bracelets or just keeping your baby away from public eye. Some people believe that hypertension, you get them because of anger or fear or because you have thick blood. And you usually treat them with stress-relieving flowers, chamomile, lemon juice, bananas, cold packs too. They think it's a warm, it's like an increased metabolism disease, so they try to cool down the body. Diabetes, they also think it's a hot illness due to vasodilation. So they treat it, usually for this, most of the part, they will send you to see a physician because they don't know how to deal with it. But it also comes into, when they come to you, keep in mind that if they think this is the cause of their problems, and all of a sudden you tell them it's something else and not explain it or acknowledge what they believe in, that might decrease their compliance. So it's important to keep the little beliefs that we have in mind when we come to treatment. Like I was saying, we either have walking barefoot, you might get like pneumonia or cold. If you have cough with sputum, and you should probably not drink milk because that's going to make it worse. Menstruating women should also avoid fish and exercise. Bile or gout is sometimes believed to arise from suppressed anger. And backaches and muscle aches, usually they think you got air caught in your back, and they will go back, put a candle on your back, and try to suck the air out. So it's important to keep this in mind when you come treating your patients, because this will affect compliance hugely. And it also helps you understand and keep a better relationship with your patients. So how to approach them? Once again, don't assume anything. Just because we mark down the word Hispanic doesn't mean we believe in everything I just said, but it also doesn't mean we don't. So we just come in different mixtures. Listen to your patients. This is with everybody. Listen to all of your patients. You'd be surprised the amount of information you can get from just listening to them. Ask questions. If there's something you're unsure about, if there's something they tell you and you have no idea what it is, most of our patients will be more than happy to answer your questions, just like we answer their questions. Don't dismiss their beliefs. Most importantly, do not dismiss their beliefs as calling them dumb, unscientific, or just simply they don't have any proof to back them up with, because this is part of their culture, this is part of who they are. Their view of medicine will greatly impact the way they perceive us, the way they approach us, and also the way we treat them. So the next person, before we go on with cultural competency, are there any questions? Yes?
I have a question on with the herbs, and like my mom, she spends about like $200 every 3 to 4 months. She has diabetes, and she sends off this one to a friend in Mexico. She gets like a bark off the tree. They send it back to her. She makes a tea out of it, and it's always trying to tell her to take diabetic medication. I try to tell her. It's like just a constant battle back and forth. And then she says, remember all those things I used to do for you guys when you guys were kids? All those things work. And so she's putting a lot of faith into the bark of the tree. How do providers sort of compromise with that?
So this is actually, if you don't mind me using this, this is the classic example of a lot of our patients doing this. And you will, most of the time, I believe, will not get them to completely give up what they're doing, but you can get them to get to compromise. So what if you take the medicine the doctor here gave you in addition to what you're doing. And that might actually be a slow start to that. So not get rid of what they're doing, but try to add what we provide, what we can provide as healthcare providers, and try to get them to understand that this is going to make them feel better, that, you know, we don't know if it's any better than what they're already doing, but if we put them both together, it'll work better and she'll get better. Also, one of the biggest things to keep in mind if they ask, even if they're taking any natural herbs, is because of drug-drug interactions. At least for most of us, this should apply. You want to make sure what your patients are taking to avoid any drug-drug interactions and to avoid any medications you get from not working. So it is important to know what they believe in. So I would try to see if you can come to a compromise of taking both instead of giving up one or the other. Anybody have any other suggestions?
I think it's
Actually, happened to me, and I used to work in Venezuela like physician, and now here in the US. But we have Native Americans over there, and they have this kind of medicine because that's what's available all the time. And many of the patients usually, when you have a really a relation with them, is when they tell you what they're taking. So what I try to do is, because I don't want to cause a harm, I want to take my medication. Sometimes I try to maybe reduce what they're doing a little bit, or try to put it in a way, or try to negotiate. You know, this medication I need to see something, you know, maybe I need to take along for these few days, or take less for the other one, or maybe you need to report in your paperwork the patient don't want to stop taking this medication, you know, and maybe check with other, you know, to see if any interaction. But I mean, you cover yourself. The patient refused to take this, but I would try to negotiate. You know, I would try to get around to the patient because they believe in that medicine. But when they come to you, it's for a reason, and maybe that medication, even though they believe, they know they are not working 100%. So you have a space to negotiate there, you know, but you need to be very, very careful, and that way you don't insult the person and say, oh, that doesn't work, you know. Maybe that's what you say.
So my name is Marta Nelson. My background is in nursing, especially in community health nursing and also in public health. Today I will be talking about dealing with these barriers that we encounter with our patients. Okay, the first thing for us as healthcare providers is to identify those barriers. So first, the type of barriers that we have are language barriers. When we encounter our patients, we have to make sure that we assess what are those barriers. We might find patients that do not speak any English at all. They might be the first generation immigrants. Probably those are going to be the patients that are going to be the most challenging for us. For those patients, we're going to need training interpreters that can transmit all the information and all the messages that we want to give to those patients, and they are also going to be helpful to help us communicate and get the information that we want from the patients too. Or we might have the patients that have some English, and this is very important, as Madeline said. Never assume anything. If you find a patient that is functional in English, don't assume that they have all the knowledge to communicate with you. It's something that, as a provider, you need to assess in your patient. The other problem that probably it's been mentioned before is training interpreters. Sometimes the patient might bring somebody to interpret for them. As we have said, it might be a problematic issue because that person might not know all the terminology or all the right way how to transmit the messages for those patients. So it's important that at some point, as always said, never offend your patient. You will not undermine that this patient or somebody to interpret for them, but politely you will say, I prefer to have an interpreter that has been trained, that will help us both get the right understanding. That's about language barriers. We also might encounter cultural barriers, and probably those are the most hard barriers that we will find, and those are ingrained in the culture. With the patients, we have the cultural health practices. For example, the ones that are related to doing different things like taking herbs, doing certain rituals that might interfere with the health of the patient. So it's important to acknowledge those and address those with the patient. We also have other cultural barriers, I'm going to call them generational customs. As we have seen, our Hispanic, Latino population are very, and they have lots of variety in what they are and how they behave. For example, the first generation of immigrants would be the ones that bring most of their cultural traditions. They want to keep it more closely to how it's at home. Those people might prefer to be treated with lots of respect, with high value, being treated especially with respect from their older. We have the youngest generations, probably the second generation. You may have the second generation that, even though speaks Spanish, might not read in Spanish, or might prefer being taught in English and have their written information in English. And they are also more acculturated to the American culture. So you have to make sure that when you deal with your patients, you have to identify those barriers. And the other cultural barrier is the health beliefs. As Madeline has explained to us, we have certain beliefs about our health. And again, some of those might seem logical, some of those might not seem logical. Never undermine a patient for what they believe about the cause of their disease. Never undermine the patient, not ignore what the patient has to say about what they believe about the etiology of their diseases, because that will help you to improve your communication. The more that you try to learn about your patient, the more trust that the patient will have on you, and the better relationship that you're going to build with your patient. The other barriers that we need to look into is socioeconomic barriers. Since my lack of resources, as healthcare providers, we always look for the best options for our patients, and sometimes we don't ask, just decide to give them certain medicines, but without looking at if they can afford it, or we want them to have certain tests. Would they have access to that specific test? Can they pay for it? Again, some things that we need to look at. Other things that we need to check is problems with transportation. Sometimes we're really fast to label the patients as uncompliant because they don't come to their appointments or because they are late. Have we asked if they can make it to an appointment, or maybe it will be easier for us to find other places that are close to where they live? It's something that we need to keep in mind. I think that we probably have addressed is the literacy level. We have to make sure that our patients understand, and especially if we're going to give them written material. If that's not an option, the best way to deal with our patients is establishing a verbal communication, making sure that they can repeat back what we have said. So enough, I have said enough about barriers. Let's see what we can do to address these things. Always. We're going to come in contact with a patient, any patient, not only a Hispanic or Latino patient, any patient. When we come in contact with that patient, we have to have in mind how to prepare for that first encounter. The first thing is identify what are our main barriers so we can target them and address them appropriately. Once we can do that, we can establish a good communication with our patient. The best thing is to establish that patient healthcare provider relationship with rapport where the patient feels trust in us. And the way to do that is not being judgmental, not making assumptions, not putting stereotypes on the patient because of the way they look or because how they talk or how we believe they're going to behave. Once we have established our first encounter with the patient and we have addressed their main health issue, we need to know what we are going to do next. And I call it an action plan. An action plan that it will include all the activities that we need to implement for our patients, but always having in consideration these barriers. How are we going to deal with these issues that the patients might have? And we do this by selecting the interventions that might work. And one of the main things to select these interventions is getting always the input of the patient. The best example I can think that Owen has given us is if the patient is doing something in terms of our health practices, like taking herbs, that if those are herbs that don't affect the health of the patient, then it's incorporating those to their normal care. Take those herbs, but also take your medicine. And sometimes we can go a step forward, and in order to help our patients, we can identify what other things can help the patient. Community resources. We can find places where they can get the help they need. For example, if they need prenatal classes in Spanish, we can find out where we can refer our patients in the community where they will get the classes that they need in their families. Let's talk about how we prepare for our first encounter. As healthcare providers have our goal, and our main goal hopefully is helping the patient and be effective on what we do. But also we have to keep in mind what's the goal of the patient. Why is the patient seeing us? It's seeking care. It's something that the patient maybe wants to get better. And the next thing is think what is our goal, what's the goal of the patient, and find a common ground between those two. Dealing with our patients, we need to adapt our communication style to fit the needs of the patients, as I said before. Keep in mind how the patient wants to be addressed. We always have to demonstrate respect at all times, and when I say respect is acknowledging our differences of what we believe, what our patients believe. Their healthcare practices might be different, what they do. They might have certain beliefs. Instead of undermine those beliefs, we have to acknowledge those. And if we do not know something about our patients, the best thing is ask. Never assume anything. Even If you don't speak the language and you are working with an interpreter, always engage in the communication because the patients know, they can know the difference when you're genuinely involved in what you're doing, when you're dealing with them. And so you need to perform a cultural assessment in your first encounter. Find what the patient thinks about their health, what are their concepts of health. You might find out different things. Sometimes patients don't, some of the Hispanic patients don't believe that not having symptoms is being healthy, and they might have chronic diseases. You also need to ask about their health practices. When they are sick, what do they do? Probably they go to see the medicine person. They take home remedies. All of this is pertinent to their care. Care help a model how we get to the common ground with our patients. On one side is the healthcare provider, and the other side is the patient. Both of us, the healthcare provider and the patient, has expectations on how that encounter will go. But remember, the expectations of the patient are molded by the health beliefs, the attitudes of the patient towards health, and previous experiences that they might have had with other healthcare providers, with the healthcare system. You as a healthcare provider have an objective, and that hopefully is helping the patient to get better. And the patient has a reason for seeking care. So you have to get a common understanding of what you can do for the patient versus what the patient is expecting. And sometimes this can get very hard. For example, if the patient doesn't have a clear understanding of what a chronic disease is. How many times I have a patient that have the expectation to be cured from diabetes because they think they can get cured. But at the common ground, we've been negotiating with the patient, explaining to the patient, no, I cannot cure you, but I can help you to deal with this disease. If the healthcare providers and the patients find the common ground, you will have a patient that will be compliant, and not only that, but will participate in their care, and you will have build a good relationship with your patient, and therefore you will have good health outcomes for your patients. To finish, there are things that you need to keep in mind when you perform your assessment. Not only think about the barriers, also the resources that are available, the sources of healthcare services where the patient can find those services. Also, if they have the means to get there, also all their resources that might be in the community, and if the patients have access to medicines. Do you have any questions?
Let's go ahead and move on to our last speaker for a few minutes, and then we'll open it up.
Can you hear me? I want to take a few minutes. Please be with me. Yes. Okay, hello. Okay. Well, I'm going to speak. Fortunately, the other presenters who already did a good job, and to cover most of the things they need to talk today. And I'm going to pass a few slides, and that way we can finish and have some time for questions. Okay, what's?
Keep going forward.
Oh, okay. Well, this is there wasn't a slide before that I prepared for that, but basically is a Sometimes we think most of the people who are insured are undocumented or immigrants, but around 40 million Americans are uninsured, and we have almost 47 million from this story. This is a fact. This is another question. Illegal immigrants consume large quantity of healthcare resources. It's a myth. Illegal immigrants are ineligible for Medicaid and Medicare. Sometimes when you hear some discussion about how illegals or how immigrants are taking the resources, you have to be citizen or you have to be a resident for at least 5 years to apply for some of the public health insurance. Let's talk about the area of fear. I think that some agencies in the United States have been doing, when they do the job, sometimes they do some fears in the family, and sometimes that fear where they impact these families and apply for example, for health insurance, whether the son have a citizenship or things like that. Last couple of years we were doing some activities to increase the number of CHIP and Medicaid because they were very low in some groups, especially minorities. And many of them, when something happened in Arizona or Pennsylvania, whatever, that noise generates some fear for these families, and they prevent their citizen kids use the insurance that they can use, but sometimes the parents don't want to go over there because they ask for Social Security from the parents, and if they are illegal, for example, they think they can be reported to immigration. But basically, we do that is just for check for income, because it's based on income that you can qualify for these programs. But we don't. That's not our work, you know, in health department. By the way, my name is Owen Quiñones. Sorry, I didn't present myself. Owen Quiñones. I work for the Utah Department of Health. The other fear of cost. In many other places outside from U.S., the healthcare cost is provided by the government. And in the United States, the healthcare is a business where people make money through the healthcare system. And when you go to a place and you don't know how much you're going to pay, and you receive the services, maybe it's not the best services in your mind when you perceive, and you pay a lot of money, you don't want to come back. Because if I don't have insurance, I pay $200, for example, for an appointment, and the doctor says, well, you don't have anything, and you pay $200, that hurts. And especially if you don't feel like you get treated or you don't get the medication you want or you need. So I think it's a balance between what do you understand for quality of services and how much you pay. And the other thing is, when you go to a place right here, sometimes you don't know how much it will cost. And sometimes there are some examples they have there, somebody goes to the emergency room and they have a pain in the stomach, and they couldn't find out. We know that in the emergency room usually is to treat some of the symptoms, and after they can diagnose you maybe later. And the person says, oh, you don't have anything today, but the bill is $5,000. So sometimes the people don't want to go to the emergency room or to a provider because the service that you receive and what you think that was not good and how much you pay is enormous. And they don't tell you up front. And when you go to other countries where they have governments, healthcare system, and also private, so that you have both, you go to a private clinic, when you need to pay, you go to the front desk and they tell you, you need to put it $10,000 and you need to bring $10,000 in cash or in credit card. But you know how much approximately it's going to cost. They don't have to be exactly, but you know up front. Right here you go and you don't know how much you're going to pay. And that's really hard for many people, What about health insurance? Like the lady asked about poverty. When many of the jobs that some immigrants have is a low pay. And many of the companies, what they are doing right now is, if you are full-time, they offer part-time jobs, and that way they don't offer health insurance. And that's an example. I think Walmart recently did that. I have a friend who is working for like a couple of years there, and they offer the new jobs part-time, and that way they don't have to offer health insurance because it's costly. And also if you work in a low-paid job and the health insurance is very expensive because the business is not going to cover 90%. The business may be covered, for example, 50%. So you need to pay a lot of money. And when you bring to home will be so little that you don't want health insurance. In the mainstream, usually, sometimes you have a person who works in construction, no insurance, maybe $25, $30 per hour, and the other partner, or the wife, or vice versa, work for the government, for example, and they don't make too much, but they have health insurance. So usually mainstream sometimes work like that, depends. But for example, Latino culture, where maybe both work low-paid jobs, and maybe both will not have health insurance. So that's a problem about access. And many of the labor also is like take care of babies from other people who are working, and usually the norm is like a $1 or $2 per hour, and that's very cheap. And people sometimes don't believe when they say that, but many people do that. I repeat, you need to be documented to apply for public health insurance. And also you see some situation where you have 5 kids and maybe 3 have insurance and 2 don't have health insurance. Because if these 3 are citizens and the other 2, they can when they were younger, but they didn't work right here, they don't have the access to health insurance. And so you can find all these mix of status, or with insurance and no insurance. The other thing is where they go, because they need to go for somewhere. First, the demand of people who need care usually is higher of the offer of the clinics that we have, especially clinics for low-income communities. And we have some, for example, Head Start, like a migrant Head Start, they have to provide some medical services for the kids who are going for those places, and the fathers and migrant farm workers, for example. Also, we have free clinics, and the free clinics, there are not too many. And some of you maybe do volunteer those free clinics, and it's basically a doctor who have a heart, and they open a clinic, and they try to see patients that try to address these health issues. But the problem is too many people, and sometimes you call, because sometimes they call me, and always where they can go. So I try to find out a list. I try to refer, I say you need to wait because just call the first day of the month because maybe they have 5 openings and you can get an appointment. But it's that kind. You can wait like 2 or 3 months and to be seen for a disease that you have in a moment, or you are sick in a moment. For preventive services, it's harder because it's luxurious to do an annual check. Something that we expect, the healthcare system expects that people have annual checks to be healthy and don't cost too much money for the healthcare system. So it's hard to get a preventive services. Dental care is horrible. It's really, really hard for many, many people. Okay. So consideration to provider is regarding to communicable disease control. Usually these places do not ask for citizenship or for legal status, or for the status that you have in this country, because they will attend with public health, like immunizations, especially for kids, or HIV/AIDS, or TB. So usually these places do not ask for this documentation, and will be almost illegal based on the civil rights law about that. So we don't want to discourage people who we think maybe they don't have papers, to don't access this, because we need to go for those kind of checks. For example, HIV, Other thing that maybe it will be invisible for us because we don't see that reality many times is trafficking, and we have an estimate of 18,000 human trafficking every year in the United States. And there are 2 main groups. Is one for domestic servants, and the other is sex trafficking. So that we need to be aware of this because there can be some signs when you are seeing patients or when you are in the healthcare system. You can pick those signs and do appropriate steps to address that. Some of the screening that you can do, it is mentioned already, is the language barrier. If you have a good interpreter, You develop a relation with interpreters, companies, and things like that. You have a protocol for your company, for your hospital, for your emergency room, and that way you don't have to say, oh, we in Arabic, or we in Spanish, oh, you know, you don't waste time in that moment. You have a protocol already for that. The other is at some point you need to talk along with the patient, because if you see somebody who is always there, well, and they don't allow you to interact with the patient, there could be a sign of something's going on. And also some questions regarding in your routine intake, question about are you safe in your home, or you owe money to your, to your employer, things like that. Also the body language, and that's a very, very good, because we learn to see this body language mean. Because body language mean maybe for one group, one thing. For example, Japanese women don't like to see their eyes, It's like nothing, it's a generalization, of course. But the tendency is they don't like to look in your eyes, especially in Japan, right here maybe it will be different. But it's a culture piece, But you will learn, and you will match what you see, what you experience, and you will understand more this body language. But you need to pay attention to those details. The other thing is I put a phone number because I think there will be no nice if you suspect that to call the police. Because maybe if you have a situation, maybe it will be a lot of fear for the patient, and maybe they can handle better. For example, the National Human Traffic Resource Center, and they can work better, And I'm finishing. And this is okay. This is almost the last one. And there are sometimes physicians who speak the language. Oh, I speak Spanish. I can communicate with my patient really well. They ask some questions. They're very, very uncomfortable, and they damage your relation with the patient. The patient don't want to come back sometimes. Like when you ask about the legal status, why you come here, what was your process? Especially when the physician know well the process, make the patient really, really comfortable, because that's a very sensitive topic for some immigrants. And some patients maybe will share the information. So just be careful with these topics. We like to talk about medicines. We love to talk about gordito, the obese. It's okay, but there are some topics that are a little sensitive. Like we say hi to another man in my country, touching right here, and if you are a little obese, or if you are obese, it's sign of wealth, because you are eating well. You have a wife who cook really good, and that's something from over Venezuela, not from here. I cook. Okay. There are some questions that are important about you assess the language, and then we talk about that. The family history. Can you tell me if you have other family members, who have this disease or this condition? Race and ethnicity. If we don't collect race and ethnicity and match with the diseases that we have, we cannot, epidemiology cannot do their work well. So we need that. We need to talk about what is your race, and usually, we can say we are white, we are Asian, black, all these races. Latinos are, the ethnicity is Latino. So the ethnicity is Latino or not Latino. So this is, and basically in your healthcare setting will tell you if you have question about that. But ask for that. And okay, we mentioned already about Medicaid. This is the last one. Okay, this is an example about all family members come to the doctor's office. We did an assessment to one of the clinics that we go about cultural competency, and there was an individual part of the healthcare system who was really angry about they come all the family, the mother, the father, the 3 daughters, and the mother was sick. And we have in a small area. She said, oh, we have in a small area. There was too many people right here. We can have only 20, and there are already 5. And of course, if we understand why that happened, we can address better the issue. Because I don't say that we are going to have 100 people there, because it's not right. But usually when somebody in the family gets sick and you are at home, and your father, if you are the daughter, say, oh, I am going to go with your mom to the hospital. And the sister, the daughters are not going to say, oh, okay, I will be here. It's no question about it. You will go with them. It's no question. It's no doubt about that you will go with them. Otherwise, it will be inarticulable. And in many families, that's the truth. So when the head nurse see that it's a culture thing, and I say to her, well, maybe we can put a sign. If you see many people right here, they have to be really put it together well. So basically, take turns if you see more than 20 people, more than 30 people right here. But at least you understand that there is a support for the mom. They are doing that not because they want to bother the clinic doing that. And when you know these details, you understand more why they're doing that. It's just culture. Okay, patients expect to be touched. Okay, I went to the doctor. I made $7.50 an hour. I had to pay $200. And the doctor, I went and he see me having a few questions. Okay, Okay, I go. I have a bill $200. He didn't touch me. They don't believe that we have a mind and we go inside and make a diagnosis. They like to be touched because otherwise they say, oh, this doctor is just, they don't believe that you really perform a good diagnosis for them. And maybe you put the best treatment possible, and maybe they don't care. Maybe they don't buy the medicine. They left really frustrated. And just miscommunication there because they like to be touched. How are you doing? Hi, It's important that the touching, part, especially when it's a diagnosis. Be told what to do. Sometimes it sounds weird in this culture, in the mainstream, because we don't like to be told. But many families like that. I expect, or I would like, Maria, that you buy the medication today, and you start today with the medication. And when you come in 2 weeks, I hope that you take the whole medication because I put in 14 pills for you. Tell what to do, and because maybe if you write down, oh, are you taking and maybe they don't know how to read your letters. They didn't understand what you said, and they don't buy anything, and they expect to be in 2 weeks. They come, and maybe they buy the medication the day before because they wasn't aware that you want that day buy the medication. Things like that. What time they once pill, one pills every day. In Spanish, once is 11, it's 11. I hear that some people, one patient I think, take 11 pills because they thought it was once. The only thing they could read is once, and because there was no, the communication. Tell the patient the cost of the service up front, very, very important. Very, very important. Even though it's hard, but if it's too expensive and the patient cannot pay that, you increase the poverty. Because maybe they make a little bit and they cannot afford that. And I think for me it's a crime, to make more for somebody like that. Tell patient the doctor expectation. You need to tell, yes?
With telling the patients the cost of services up front, many times how are you going to, unless it's just a straight, they show up at a clinic and it's a follow-up where you would maybe know that cost up front. Other times, more often than not, you wouldn't know because you don't know what test you're going to order, you don't know what's going to happen. And so, do you just overestimate to give it?
Well, it's like if you go to the store and you want to buy these pants and you don't know the prices.
Yeah.
Will you pay that? Will you take it? Especially if it's an expensive store. If I want to order, am I right? I would say this can be cost between $1,000 to $2,500. Are you okay with that? I need this test because I need to check in this. And for me, it's very important. I know it can be costly, but I want to check with you. What do you think? I don't know.
Okay.
Yes.
I'm just going to say that the doctor or whoever is offering the test can then say, this is what I'd like to do, and tell them how much. So initially, there's being a people in front, but then when the doctor says, I'd like to run these labs or whatever, or these tests.
And the problem is, for me, we have a healthcare system which is abusing individuals. I went to take a test, and the doctor didn't tell me it was included in my insurance. I had to pay $60. Every time they go to a lab test, I call, because they say, oh, you can call this number, but they don't push you to do that. They are really sneaky. And so I get on the phone and say, and person has the needle right here. So yeah, wait a minute, let me confirm that this test. And they say, well, we don't know if it is covered or not. Well, but I need to know because I don't know if you have money to pay that. You know, and maybe I have money to pay that, but I don't want to compromise something that, you know. So that's the. Okay, I think maybe we can open to questions. And I think all this panel say about trust. If you get the trust of the patient will take whatever medication you want because they trust in you. And it's a relation, you develop that. If you can communicate with them well, you know, they impact the trust and you improve the chance the patient that, you know, the treatment that you are providing. You know? But there were a lot of things, the expectations, you know, that you said is very important also to know that, the expectation from both sides. But let's open to questions. We have a few minutes, right? Carrie. And yeah. Yes?
You mentioned about not asking what country they're from. I think it's important to ask that because we had a chief resident in surgery, you know, when I was a resident, and he was complaining of chronic headaches to the point that he could not tolerate the headaches, and a CT scan showed multiple spots in his brain. And initially they thought he had cancer, but it was not until he volunteered the information that he comes from this country where they love to eat pork. And sometimes when you eat uncooked pork, you can eat, you know, those tapeworm eggs or whatever. And that's exactly what he had. So they were contemplating on doing surgery, but then when he gave that information to them, then, because the surgery was postponed, and then they just watch him and look for medications, and he's still doing fine now, and those are just calcified, you know, I guess, larvae or eggs in his brain that he have to live with for the rest of his life. So I think that we just need to find a way on how to ask that question in a diplomatic way without hurting or you know, affecting our relationship with our patients.
I think the patients are really proud to say where they come from. It depends how you ask and how you came from this country. You know, all these questions is what make comfortable. You're right. It's important for epidemiology reasons to ask what country somebody come from, especially in those situations. Yeah. But it's the way how you establish the relation, you know, with the patient. Yeah.
Oh, I just wanted to make a comment. Sometimes.
I cannot hear well.
Sorry, I just want to make a comment about the eye contact that you mentioned. Like sometimes in some cultures, you know, it's not good to see person, but I think in Latino American culture, it's kind of important to take that time to have that eye contact because there's so many, especially elder patients, that they'll say, "Oh, the doctor didn't even look at me; they just kept on writing it down." It's never been mental. The other thing I wanted to also comment on was the fact that we have to realize that not everyone from Latin America actually Spanish is their first language. There's some dialects, like for instance, some parts of Central America, like Mesoamerica, there's dialects that was their first language. So we can't always assume also that just because they're from Latin America, they're going to speak Spanish.
Right. Right. Yes. Yes.
I was wondering, you mentioned diabetes a little bit, and we've been having kind of these conversations about dietary changes and recommending dietary changes and how that can be difficult across different cultures. Do you know kind of how to go about that, or any resources of how to recommend some of those dietary changes?
Well, I think Marta put something in the common ground. Yeah, I think we were doing some diabetes tests and blood pressure and BMI in Middle City with the annual health fair, and we find out many people, you know, who have not many people, you know, an important number of people who have high glucose in that moment and new. And also they know a year ago, a couple of years ago. So what we find out is it's a process of change of behavior. It's really, really hard. The medication is really expensive, you know. And what we try to do with Midland City is try to have a small group. These people come because it's a shock. You know, you are diabetic today. Yesterday, you know, before you were okay. And try to have a small group of people who were elevated, you know, the glucose, and they talk each other, you know, about resources, about bringing speakers to the group, but they can address that issue by themselves. They can bring resources, because I think it will be more easier to help them to change the behavior and it healthier. I think it is. But of course, I think to have resources list also will be okay. And also sometimes isn't like a denial, you know, like especially chronic diseases, linked with God, linked with no resources, linked I am the oldest and my sons need to go to college and I could be a burden. I don't want to be a burden. I want to, you know, the sacrifice, parents, you know, things like that. So I think involve other family members also is a key because sometimes the daughter or the son is very, they feel really responsible for that thing, for that diet and things like that. So I think involve them and talk to each other, you know, asking the permission of the mother. You know, I would like to talk with your daughter also with you. Can you come together next time? You know, that way we can talk. And say, that person will help the mom. They will make your work easier.
I can make a comment to that. Sometimes not making a complete life change, but a small one goes further long ways. So instead of saying completely stop your diet and start eating totally vegetarian and organic, maybe just say cut down your soda intake from 3 cans a day to 1 a day, and then 3 months after that you can suggest something else, but sometimes that goes a long way. Rather than just telling them you have to go on a diet, you can't eat this anymore, I'll see you in 3 months.
There's actually a diet called not a diet, but it's called the traffic light diet, and it's been modified for Latino-based foods, and it's out there, it's been validated, and it's been incorporated across the country, and it's actually really good to use.
What's it called again,
It's called traffic light approach.
Okay. Oh, green, yellow.
Yeah, and it's all, they use more like Latino-based foods versus American-based foods.
I just want to make one comment to rise in diabetes and obesity, I think, and primarily in people who are poor. And I talked about the statistics of Hispanics being in high poverty, but if you think about it, vegetables, fruits, vegetables cost more than what it costs to get a 99-cent cheeseburger or whatever. Not only that, but a lot of these people were, you know, in households where both parents were working, so their activity level is actually, you know, really restricted. You come home from working a full day's work, last thing you really want is to, you know, go out and jog or whatever. So it's really hard to kind of change those things when you look at these other factors that are affecting. And I think a lot of the, there are studies that show that there's restaurants actually open up, like McDonald's, fast food restaurants, are more concentrated in areas with higher poverty. So there's studies on that, so I can give you some of those if you like.
And sometimes when we do the BMI, and I had the table, you know, these, you know, all the classifications, and I pointed that number to her, and the person read. You know, I don't say you're obese, you are, you know, the person read by themselves. And sometimes I see the person 2 years after, and they say, you call me obese. And I say, well, I didn't. You read it, you know. And I think these few things, you know, playing with things maybe help a little bit.
Any last minute questions?
What is this? Ah, yes.
You touched on herbs, but what about medications? I know a lot of people who, send for medications because they can't get them here. Or I know we've got low-cost programs, but if you aren't familiar with the medication that they're bringing back, how do you incorporate that? Because that can have a lot greater drug interaction.
Try and find out where they're getting it from. I mean, I know to us, adding more work to our table, it's kind of rough to get it done. But I would kind of ask the patient if they know what it is from to bring you the original package if there's any. And if you're unsure about it, maybe ask them to, and this is rough, ask them to maybe discontinue the use and try what you're doing first and then slowly bring it back in. But I would try and do as much research as you possibly can before completely saying you have to stop taking this and then we'll bring it back in. And sometimes just asking them, they might tell you where they got it from. If they bring it in and they bring the package, that might be your best bet.
I have a friend, he used to put it himself, lincoln. It's an antibiotic for a specific infection. And every time he have a cold, he get a lincoln, you know, and one time he asked me to put it. Of course, I didn't do it because I talked with him, and he's an economist in his country. He's, well, you know, he's not an expert in health, but it takes me time to explain and the powerful antibiotic he's taking and what he's producing in his body and other people maybe and that way he can stop. But remember, when the patient came to you and he says he's taking that, it's because something is not 100% good what he's doing. So he put the coin of trust in you, just coming. And is this game, the first visit, you know, make small steps and understand, listen, even though they take a little more time the first time, but you engage with that person the first time because for some reason they can, you know.
Last minute questions? Wonderful. We want to thank you all for taking the time to come and listen to us. We do really appreciate it. So thank you very much.
An applause for you.
We just want to thank the Office of Inclusion and Outreach for providing our snacks and for sponsoring our event, and Latino Medical Student Association for being involved, and we hope to see you at our next event. Have a good night.